So, gastroesophageal reflux disease, abbreviated as GERD. Gastro means stomach and esophageal means esophagus, which is the tube connecting your mouth to your stomach. And reflux means that the food in your stomach re-enters into the esophagus. And this is not how it's supposed to be. Food should move from your mouth to your stomach and not in the opposite direction. And that's called vomiting. Why is this happening? The most common reason is because the sphincter between the esophagus and the stomach is not closing as it should. And if that sphincter would close, then the food would simply not enter into the esophagus. And now that the food enters into the esophagus, it damages the wall of the esophagus. Why? Because the stomach content is very acidic. And the stomach wall is much more resistant against that acid, but the esophagus cannot tolerate this acidity, and therefore erosions happen. And this is painful. It can cause heartburn, which is a burning feeling around the heart and the upper abdomen region, and it usually gets worse if you lie down or after you eat a big meal. And the food can move up to the esophagus all the way until your mouth. And this is what we call regurgitation. You will burp, you will have a salty acid taste in your mouth, and this can even make you feel nausea and provoking vomiting. And some people even have difficulties swallowing because of these problems. And we call all these symptoms esophageal symptoms because they are all related to the esophagus. But there can interestingly also be extra esophageal symptoms which are not related to the esophagus. And these are cough, hoarseness, globus feeling, and difficulty sleeping. And these symptoms are bad in itself, but there can be unfortunately even worse complications like aspiration of the stomach content into your lungs, ulcerations, and the worst of all, adenocarcinoma, which is a cancer of the esophagus. And it takes 5 steps to create cancer from GERD. The first step is that the wall of the esophagus undergoes gastric metaplasia. Metaplasia means that one cell changes to another cell, and this means that esophageal cells change into gastric cells. The second step is that these gastric cells change into intestinal cells, and this is called intestinal metaplasia. The third and fourth steps are dysplasia, which means that the cells form a bad shape. So metaplasia were a change from one cell to another, but dysplasia is a change in the cell's shape. And we can divide dysplasia into 2 types. We have low grade and high grade, based on the severity of the shape of the cells. And the last step is when high grade dysplasia form a cancer called adenocarcinoma. So how can we diagnose these patients to prevent this from happening? The symptoms themselves are already indicating that this is a gastroesophageal reflux disease, but a very useful tool called endoscopy can be used. And this is a tube with a camera on the tip of the tube that we enter into the patient's mouth and down through the esophagus until we reach the stomach. And here we check the gastroesophageal junction. We will use a classification system called Los Angeles classification to divide the patients into 4 groups based on severity of the esophagus and see how it's damaged. So when we look into the esophagus with the endoscope, we will see mucosal folds. And these are foldings of the esophageal wall. And if we see erosions that are only affecting one mucosa fold, then we call this grade A or grade B. The only difference between A and B is that A is having less than 5 mm erosions, whereas B is having more than 5 mm erosions. Grade C and D are affecting more mucosa folds, and the only difference is that grade C is less than 75% of the circumference, whereas the grade D is more than 75% of the circumference. And if we suspect that the reflux has caused an adenocarcinoma, we need to take a biopsy of the esophageal wall with the help of an endoscope. And we take a biopsy, we cut a piece of the wall, and then we look at it under a microscope to see at which step the disease is in. And these are the steps that we talked about, namely gastric metaplasia, intestinal metaplasia, low-grade dysplasia, high-grade dysplasia, and adenocarcinoma. And except for endoscopy, there are other methods that we can use to diagnose patients with GERD. We can, for example, do a 24-hour pH monitoring of the esophagus. And if the pH is acidic, then we know that the stomach acid is being refluxed into the esophagus. And how do we measure the pH down in the esophagus? We can either use a tube that we enter through the nose into the esophagus and place it 5 centimeters from the lower esophageal sphincter, and we keep it there for 24 hours to measure the pH of the esophagus. Or we can use newer techniques where we put a capsule at this location, which is much more convenient for the patient than to have a tube through the nose for 24 hours. The other benefit of using a capsule is that we can keep it there for a longer time. The Bravo capsule can be there for 48 hours, and the OMOM capsule can be there for 92 hours. So now that we have diagnosed the patient with GERD, we need to treat it. We can use 3 different methods: lifestyle medications and operations. And when the disease is mild, then lifestyle can be enough. But if there are still a lot of symptoms despite lifestyle changes, then we can use medications. And if medications does not work or the disease is very severe, then an operation can be done. So which are the lifestyle changes that we can do? Lose weight, don't eat big meals late in the evening, don't lie down after a meal, don't eat sweet dishes, don't drink alcohol, don't smoke, and sleep with a couple of pillows so that your upper body is a little bit higher up to prevent reflux during the night, which could cause aspiration of the food into your lungs. So these are the lifestyle changes that we can use in mild disease. But if these are not enough and you still have symptoms, then we can take medications. And we have 3 groups of medication worth remembering: Antacids, H2 receptor blockers, and proton pump inhibitors. Antacids and H2 receptor blockers are used in mild disease without any esophagitis, which means that without any inflammation of the esophagus. The typical H2 receptor blockers are Cimetidine, Ranitidine, and Famotidine. As you can see, these are ending with tidine. So Cime, Rani, and Famotidine. And whenever there are many symptoms and esophagitis, then proton pump inhibitors can be used. And the typical proton pump inhibitors are Pantoprazol, Rabeprazol, Omeprazol, and Lansoprazol, and Dexlansoprazol. And as you can see here, these are ending with prazol. So Panto, Rabe, Ome, Lanzo, and Dexlansoprazol. So to remember this, we use a mnemonic called PROLED. P, Pantoprazol, R, Rabeprazol, O, Omeprazol, L, Lansoprazol, and D, Dexlansoprazol. And if these medications does not work, or if the disease is severe, then we can do an operation called Nissen fundoplication. And that is when we take the fundus part of the stomach and wrap it around the lower esophagus to create an artificial sphincter that increases the pressure and thereby close the connection between the esophagus and the stomach. Thank you very much for listening.